session 2017 CPT update. I'm your host, Maggie Stankiewicz, and I'm pleased to welcome you to today's event. Before we get started, I'd like to give you a little bit of background on Advize Health. At Advize, we analyze processes, implement solutions, deliver quality educational opportunities for healthcare entities of all sizes. We offer an exclusive catalog of services including HIPAA and compliance analysis, medical documentation auditing services, and educational programs for a number of specialty-specific topics. The webinar that you are about to view is just one of many services that Advize Health's advisory sector has to offer. We provide the medical billing and coding community with 30 free CEUs per year through our monthly webinars and coding newsletter. Our priority and promise to the healthcare community is to always tailor our services to our clients' needs and budgets. We have an excellent and familiar speaker for today's event, our very own QA specialist, Melissa Jewett. Ms. Jewett is a certified professional coder and a certified professional medical auditor with over 16 years of experience in the medical billing and coding community. Her expertise is in multiple specialties including general surgery, family medicine, evaluation and management, DME, and ambulance coding. Ms. Jewett is an informative and experienced healthcare speaker and has participated in conferences nationwide. Melissa has worked closely with a number of physician practices in order to implement EHR systems. Now for some general housekeeping items. Today's webinar will include time for a Q&A session at the end, so please be sure to submit all questions you have to all organizers. 3 to 5 business days after the presentation, attendees will receive a PDF handout of the webinar, along with a certificate for 1.5 CEUs. I'll now turn it over to Melissa to begin the presentation.
Hello, this is Melissa Jewett. How are you doing, guys? Good afternoon. So I was on mute, and I think you can all hear me now. All right. So Maggie, thank you for that opening, and so you don't need to know any more about me because you already know everything about me. So today we're going to go over the CPT 2017 updates, and here is an overview of the chapters that we'll be touching upon. So CPT 2017, right around the corner. A quick snapshot of the changes by chapter. You'll see some of the chapters had very small revisions or deletions, like the E&M chapter just has 1 deletion, so that's fantastic. Anesthesia, no changes. Integumentary, just a few small changes there. And then we start getting into some of the bigger changes around musculoskeletal, respiratory, cardiovascular, small changes with digestive, GU small, nervous system a little larger. And then you'll see in the medicine section there's quite a big change happening there. And a lot of changes in Category 3 codes, which we probably won't really get much into, but those are the temporary codes. So when new codes are issued, that affects a lot of the changes in the Category 3 area. Just a refresher on when you're looking at your CPT 2017 book, these are the symbols that you'll be noticing in your book. And I'm sure you're familiar with these already. The circle, which indicates a new procedure was added, the add-on sign, and so on. All right, so we'll get this out of the way, quick and easy. Anesthesia and auditory, there was no changes. Yay, we don't have to worry about it. So moving into the evaluation and management section. This year, 2017, the chapter received only one update, which is fantastic, but this is a pretty big update. So I have been doing a ton of audits and seeing this code 99420 has been billed with such high frequency across the board. This code is for administration and interpretation of a health risk assessment instrument, and this code is now deleted. So the code has been replaced with two new codes. Now you should report either 96160 or 96191, which are now located in the medicine section of the CPT manual. And these new codes, the 96160, are broken into two codes, basically the difference being that it's an administration of a patient-focused health risk assessment using an instrument with a scoring tool, or it is a administration of a caregiver focus. So the difference being patient-focused or caregiver focused. Who is answering the questions on this assessment? So when we're taking a look at this change where the deleted code, the 99420 for the health risk assessments, we've seen this build with high frequency over the last couple of years. So now it's just split into two new codes, so make sure you update your coding if you have this on your charge slips or whatever. There's two new options for this code. So the intent of the original code, the 99420, that code was created to capture practice expense. It's a service that's typically performed by a non-clinical, or you could say like, a clinical staff member. So this is, it is an RVU'd code. It is a paid code by many plans, and it was to capture that extra expense. So you'll see that there is a lot of insurance carriers or plans. They are suggesting that for certain types of risk assessments that you actually resource other CPT codes. And here's an example of some of the common instruments that are used for risk assessments. And they are mapping to different codes. Very few of these are mapping to the new codes, the 96160 and the 96161. You may see that over the next year that plans will start to utilize these new codes more frequently for these types of services, but at this time most of the payers are still suggesting that you use the other codes that are in existence in the book. And here's a little coding exercise that I just was going through, and you guys can take a look at this on your own after the webinar, but it's just showing again that the code 99420 is being replaced by the two new codes, or you should reference the other risk assessment codes such as 96110 to see if it's more appropriate. And here's some guidance from Blue Cross Blue Shield of Vermont, where they are stating that the 99420, which is the deleted code, is not a direct code transition for 2017. So the code, specifically for the Vanderbilt screenings, they're stating that you should be using 96127. Here's a little more coding exercises. This is an example of a risk assessment, and this is called the CRAFT risk assessment, which would be billed with the 96160. And this is regarding alcohol and drug use. So in terms of the caregiver-focused code, again, this is the case where, for example, a mother of a patient is filling out the questionnaire. and they're answering the questions for the patient. So that would be, in that case, you would bill the 96161. Okay, moving into modifier changes. So that was the end of the evaluation and management changes, just one code there, deleted with 2 new codes replacing. And now for modifier changes. So for modifiers, there is a new telemedicine modifier. It's modifier 95. And this is regarding the services that are rendered via real-time interactive audio and video telecommunication system. And this is also taking the place of Medicare's modifier GT. There's some proposed physician fee schedule updates. The new evaluation and management codes will have the same payment. So there's been some of the changes that are made here in the 2017 CPT updates were to create, to fix some issues where there was misvalued codes, and we're going to get into more detail about that later. But a lot of the surgical and procedure codes that are billed were considered misvalued, and you'll see a large update around that to clarify that. Okay, moving into the integumentary system. There's 2 revised codes and 1 deleted code. The revised codes are 10030 and 19298. And these codes are revised with only a minor change. CPT removed the moderate sedation symbol from the code, which means moderate sedation is no longer included in the billing of this code. If moderate sedation is performed, you will reference a new code to bill in addition, and we'll get into detail more about that in a bit. So this code, Integumentary code 11752, was deleted, and this seriously has caused me some major headaches in the past. I hated coding for this because it was like ridiculous when a patient has the tip of their finger is amputated. I searched and searched all over in the musculoskeletal section of my coding book, and I could not find it anywhere. So it turns out it was in the skin section of coding Integumentary. So now you'll see that instead of reporting this deleted code from Integumentary, they've moved it into the musculoskeletal section, and there's 3 separate codes that you could reference here: the 26236, 28124, and 28160. Okay, musculoskeletal. So here's a bigger change: 11 new codes, 8 revised codes, and 8 deleted codes. So you'll notice in the red, those are our deletions. So we have 21495 and 22305 are deleted. Now we should be reporting for the open treatment of a hyoid fracture, report 31584, and that is moving into the respiratory section of CPT. Or the closed treatment of vertebral process fractures are now being reported with E&M codes only. We also have a deleted nervous system code here, the 22851, which is used commonly with nervous system and spinal procedures. 22851 was the application of intervertebral biomechanical devices, such as cages. This was an add-on code, and now we are being told by CPT to report 22853, 22854, or 22859. And these 3 new codes are add-on codes, which are intended to be reported in addition to the primary procedure. So these would not be applicable to modifier 1551. And we're going to go into more detail around these nervous system codes. So going into detail about the 22853, the new add-on code. This new code is insertion of an interbody biomechanical device with integral anterior instrumentation for device anchoring when performed to intervertebral disc space in conjunction with interbody arthrodesis, each interspace. So this is an add-on code, like I said before. We also have this second add-on code, the 22854, which again is the insertion of an intervertebral biomechanical device, and this one is in conjunction with the interbody arthrodesis. And the 22859 being the same code descriptor, except for this is insertion of the intervertebral biomechanical device without interbody arthrodesis. And the clinical example for when you would use the 22859 CPT, the AMA CPT provided this example here of a 50-year-old male who undergoes an anterior cervical fusion of C4 through C6 for a C5 pathological burst fracture caused by metastatic carcinoma. Note, code 22859 is an add-on code that represents the additional work for insertion of the biomechanical device. Arthrodesis and or bone grafting would be reported separately using the appropriate codes. So updating the musculoskeletal system, we find codes 22206 through 2226, and these are relating to osteotomy of the spine procedures. There is some revised text here in CPT, and CPT is also making note, you'll find this throughout the spinal section here, that there's a lot of notes around modifier 62. So a number of the codes in CPT have a new description here stating that you should not be using modifier 62 with many of these spinal codes. So take a look at that and adjust your coding and billing and talk to your surgeons. Make sure that they have an understanding that co-surgery is not payable in many circumstances now. And you'll see that that's listed here. This is a snippet of what the CPT Manual 2017 looks like, and it says right here, do not append modifier 62 to bone graft codes 20900 through 20938. And you'll find that comment throughout CPT. So you might be wondering why are they not paying for this, the modifier 62, the co-surgeon modifier? And a lot of this has to do with, again, how CPT and CMS identified that there was a lot of misvalued codes. And also, in addition to that, you'll find that with the changes in the way that we deliver medicine and deliver care, that the providers are not always performing these services like they did originally. So now procedure time is becoming less. We're able to do more minimally invasive surgery, where the providers are able to be in there quicker, in and out quicker. So it's just reflecting the change in medicine. Again, here's another note around modifier 62, and this is specific to arthrodesis and spinal instrumentation. So no longer appending modifier 62 to these codes. And we also have an update around code 22830, the exploration of spinal fusion. So there's 4 new codes in the musculoskeletal system section of CPT, and they are 22867, 22868, 22869, and 22870. And they have been established to report interlaminar, intraspinous process stabilization, distraction device insertion with and without decompression. And you'll notice that originally these codes were reported Category 3 codes, so that's where you'll find that change in Category 3, where there's new codes being added to CPT. So go into more detail around these interlaminar intraspinous process. procedures with or without fusion. Code 22867 would be reported for the single level, and code 22868 is the second level. And you would list this separately in addition to the code for the primary procedure. You'll also notice that there's insertion of intralaminar intraspinous process stabilization distraction device without open decompression or fusion. And then again, it's broken into single level and second level. And then we also have here the same code descriptor, but without fusion, including image guidance when performed, with open decompression lumbar, and we have that single level and second level. And all of these, I just backed up to the slide previous, all of these codes are for the lumbar area. So to provide a clinical example, AMA CPT provided these examples for code 22867. They describe this procedure as follows. A 66-year-old female presents with a 6-month history of progressive low back pain and leg pain, unresponsive to conservative treatments, including physical therapy, oral medications, and an epidural steroid injection. So that's medical necessity, right? Anybody that does spinal procedures knows you have to go through all those steps first, prove medical necessity. An MRI demonstrates severe spinal stenosis at the L4 through L5 level, and the patient is scheduled for L4 through L5 lumbar decompression and implantation of an intralaminar intraspinous process stabilization distraction device. That is code 22867. We also have a clinical example here for 22868. Again, a 66-year-old female presents with a 6-month history of progressive low back pain and leg pain, unresponsive to conservative treatments, including physical therapy, oral medications, and an epidural steroid injection. MRI demonstrates severe spinal stenosis at L3 through L4 and L4 through L5 levels. The patient is scheduled for an L3 through L4 and L4 through L5 lumbar decompression and implantation of intralaminar intraspinous process stabilization distraction devices. The L4 through L5 level has been completed, and now the L3 through L4 level is addressed. So this is an example of the 22868, which is the second level. We also have clinical examples here provided from AMA CPT for the 22869 being a single level without open decompression or fusion, and a clinical example of the 22870 being the second level without open decompression or fusion of the lumbar spine. So we have deleted and also new codes in musculoskeletal system. We find that 27193 and 27194 were deleted, and the new codes are now 27197 and 27198. So the deleted codes were for the closed treatment of pelvic ring fracture, dislocation, diastasis, or subluxation, and we're now told to report this code when done without manipulation, the 27197, or with manipulation requiring more than local anesthesia with the 27198. Okay, so I know that we have some attendees in the room that do podiatry coding, and there was some major changes made around bunionectomy codes, which is pretty exciting because I know that I used to pound my head off the coding book when I looked at those procedures. And so what's really cool about this change is that CPT took a look at the bunionectomy codes, and they basically what CPT did was they removed all of the names, all of the funny names like Keller McBride, Mayo, Silver, all of that stuff that doesn't really mean much to a coder. They removed those names and they put in the coding descriptions. So now you'll see that the codes are revised to state what was performed. So, for example, here we have 22820 or 28290, a simple exoectomy, which used to be called the silver type procedure. We're now reporting that with 28292. We have a deleted code 28293, and now we're reporting this code, which was the bunion procedure with resection of joint with implant, and now we're reporting that with 28291, which is listed here below that in the green. Deleted code 28294 in the red. CPT is now explaining that this procedure, which was the Joplin type procedure, is now being reported with 28899. And we have a new code here, 28295, a correction of hallux valgus bunionectomy with sesamoidectomy when performed with proximal metatarsal osteotomy, any method. So basically, like what I said at the beginning there, they're just removing a lot of the names and putting in the details so we can figure out, you know, as coders, we look at like ectomy and ostomy and otomy, and are they incising, are they removing, and now we can actually look at these codes and figure that out. So this was a great change. You might not think so because it's new, but it really was a good change. In addition to that, you'll see that there's a number of revisions around bone biopsies. Open bone biopsy is revised here to give a better example of what substitutes a superficial bone biopsy. So basically, the rule of thumb is when you're doing a bone biopsy and you're looking at the difference between 20240 and 20245 being superficial or deep, really you could think about it as like superficial is close to the skin. So if it's a bone that you can touch and feel on your body close to the skin, then it's probably superficial. If it's a deep, deep bone and it's under muscle and under, you know, subcutaneous tissue, you don't really feel it. For example, if you were to push on your thigh right now, like I'm pushing on my thigh right now and you can't see me, you can't feel your femoral bone. You can't feel your femoral shaft, most of us. So that is an example of a deep bone, and that would be a deep bone biopsy. Again, there's some more revisions here around the bunionectomy codes. The 28289 was revised to include the words without implant, and the 28292 was also revised to include with resection of proximal phalanx base when performed any method. And then the 28296, the addition of the words any method was added there. More revisions in the bunionectomy section. 28297, we now find the words with first metatarsal in medial cuneiform joints arthrodesis, any method. And this used to be called the lapidus type procedure. 28298, with proximal any method was added there to the code descriptor. And 28299, with double osteotomy any method. So here's some cool pictures of bunionectomies. And these pictures you'll find in your CPT manual, and there was a bunch of them in there. We just picked out a few. Okay, moving into the respiratory system. We have 9 new codes, 8 revised codes, and 2 deleted. So the major change here around laryngoscopy is that the word flexible was added and they removed the word fiber optic. So basically that is just an advancement in healthcare, the way healthcare is delivered. You know, fiber optic procedures are not done anymore, and primarily providers are doing flexible scopes. So these are the revisions made around that. In the blue are the revised codes, and then in the green are the new codes. So we have 31572, which is a laryngoscopy with ablation of destruction of lesions with laser, unilateral, and 31573 with therapeutic injections, unilateral, and 31574 with injections for augmentation, unilateral. And again, we see the 31579 was revised to include the word telescopic. So minor revisions made there. And then we have a deleted code 31582, laryngoplasty for laryngeal stenosis with graft or core mold, including tracheostomy. And now CPT is stating that we should report one of these new codes, the 31551, 31552, 53, or 54. And basically what's happening here with these codes is they're broken out by age. So we have with graft, without indwelling stent, younger than 12 years, without indwelling stent placement, age 12 years or older, and then with graft with indwelling stent placement, younger than 12 years, and with graft with indwelling stent placement, 12 years or older. Here's some more revisions in the respiratory area with 31584. Again, the words in the green is what CPT added. So now they're adding into the code description fixation of plating of fracture, which includes tracheostomy if performed. Also, we see the 31587, as discussed previously, is now listed without graft placement. And 31588 is deleted. To report this code, you would use the 31599, and this is the laryngoscopy, which is used oftentimes when there's burns or reconstruction. And then there's two new codes, 31591, laryngoplasty medialization unilateral, or 31592. All right, moving into cardiovascular. So this is a big section, a lot of changes. 19 new codes, 9 revised codes, and 14 deleted. So 3 of the deleted codes here are the 33400, 01, and 03, and these are the valvuloplasty aortic valves. And now these codes should be reported with the new codes, which are the 33390 or the 33391. And these are valvuloplasty aortic valve open with cardiopulmonary bypass, and we have simple or complex to choose from. More deleted codes here. We have the 35450, 52, 58, and 60, all deleted, as well as the 35471, 72, 75, and 76 are deleted, and CPT will reference the new codes to report as listed here in the green. So here's more detail around these new codes and what they are for. So we've got the transluminal balloon angioplasty, open or percutaneous, including all imaging and radiological supervision. So radiological S&I, that was a big change last year in CPT 2016, where many of the procedure codes, the surgical procedure codes, now include imaging and radiological supervision and interpretation. So the new codes are following that rule. And you'll see that the first code here, 37246, is the initial artery, and then the 37247 is each additional artery. And then the second set of new codes listed at the bottom, 37248, is for the initial vein, and 37249 is for each additional vein. And then we have the new code 33340, which is the percutaneous transcatheter closure of the left arterial appendage with endocardial implant, including fluoroscopy. So again, that's including the imaging. And you'll also notice that it's including the radiological supervision and interpretation. We also have the new code 36456, which is the partial exchange transfusion blood, plasma, or crystalloid, necessitating the skill of a physician or other qualified healthcare professional. And CPT guides us to not bill this code in conjunction with 36430, 36440, or 36450. We have two more new codes, 36473 and 36474, which are for the endovenous ablation therapy of the incompetent vein extremity, inclusive of all imaging guidance and monitoring, percutaneous, mechanical or chemical, first vein treated and subsequent veins treated. And I apologize for anybody that does hemodialysis coding, but you want to take a really, really close look at your 2017 coding book, because there are now 2 full pages of dialysis circuit notes and definitions. So a huge amount of clarifications and examples were provided by CPT and AMA there. So take a close look, dive into that, and just really read over it as you get going here at the beginning of this year. So we have some deleted radiology codes, the 75962, 75964, 75966, 68, and 78. And these codes, these radiological codes, are now to be reported with the 36902, 36905, 37246, and 37247 from the cardiovascular section, which is in line with what we were talking about, where the imaging, the supervision, and interpretation is now being wrapped into the surgical code itself. Same thing with the 75791. And then here we go a little bit around the dialysis coding. So 36147 and 36148 were deleted. Now these codes should be reported referencing the new codes 36901, 02, 03, 04, 05, or 06. And the 36870, thrombectomy, percutaneous, AV fistula, including mechanical thrombus, extraction, and intragraft thrombolysis, is now being reported using the new codes 36904, 05, or 06. And in cardiovascular, we have a number of new codes here, which we've been referencing in these other slides. Again, the 36901, 36902, and 03. And these are for the introduction of needles and or catheters, the dialysis circuit, with diagnostic angiography of the dialysis circuit, including all direct puncture and catheter placements, injections of contrast, all necessary imaging, again, so imaging's included, from the arterial anastomosis and adjacent artery through the entire venous outflow, including the inferior and superior vena cava, fluoroscopic guidance, radiological supervision, and interpretation is included. So really important. Many of these codes, like I said earlier, in 2016, many codes in CPT now include the radiological supervision and interpretation, and CPT is following that same suit with these updates in 2017. So what's important around that is, what are you documenting? If you are billing a code that has radiological supervision and interpretation inclusive to it, then you should have documentation in your record of the radiological supervision and what is your interpretation of that. So you just don't want to be caught in an audit where you're not getting paid for the surgical procedure that you performed because the radiological supervision and interpretation is inclusive to it and you're not documenting it. Again, we have more new codes here in the cardiovascular system, which we've discussed on previous slides. and then the revisions to the cardiovascular system. So in the blue, you'll notice the revisions, and in the green, you'll find what was revised. So in the CPT descriptor for replacement of aortic valve, now the word open has been added in reference to the three codes of 33405, 06, and 10. And for the code 36476, the words were added subsequent veins. And the same update or revision was made to the 36479. Subsequent veins was added there. So 37192, the revision here, CPT now includes the wording that they removed. Actually, there is no wording, it's just a symbol was removed, so the moderate sedation symbol was removed from this code. Okay, digestive. So for the digestive system section of CPT, there's only 2 new codes and 4 revised codes. And the new codes are 43284 and 43285. And this is a laparoscopic surgical esophageal sphincter augmentation procedure placement of sphincter augmentation device, such as a magnetic band. And now CPT is telling us to not report the 43284 in conjunction with 43279, 43280, 81, or 82. There's also a code for the removal of the esophageal sphincter augmentation device, so that would be coded with the 43285. And the largest revision that was made in the digestive system was removing the moderate sedation symbols from a number of the digestive system codes. You'll see, I was reading an article about the GI doctors and how they're going to be billing for their procedures. So take a look at your CPT manual and think about the processes that you have in place in your practice. So if you are running a GI office and your provider, your GI doctor, is doing, endoscopies or colonoscopies, and they are administering the moderate sedation, then you're going to want to take a look at this code change and this revision, because there is going to be some new coding around that. And I'll get into detail more about that. Okay, taking a look at the GU system, we only have 1 new code and 1 revision. The new code is 58674, which is a laparoscopic surgical ablation of uterine fibroids, including intraoperative ultrasound guidance and monitoring radiofrequency. So this might be just one change and something you might just look over and not take a lot of thought around, but I think that this is a great change. I think that this is an area that plans will begin to focus on, because it's an awesome substitute for doing a hysterectomy. So a number of, oftentimes I should say, patients who have large uterine fibroids are candidates for a hysterectomy, and that is quite a major surgery. And now there is this new procedure, which is a laparoscopic surgical ablation of uterine fibroid. So now there is a more minimally invasive type procedure. And so you probably will look to and see this in the future where plans are going to require this. This is medically necessary, and that you may have to prove why doing a hysterectomy would be the preferred method if that's what your provider is trying to do. And then we have a revision in 2017 here. Many of the GU codes, again, are removing the moderate sedation symbol from the code descriptors. Okay, looking at the nervous system. We have 9 new codes, 1 revised code, and 4 deleted. The deleted codes are listed here in the red, and CPT is guiding us to delete or to report instead of the 62310 for the injection of diagnostic or therapeutic substances, including anesthetic, antispasmodic, opioid, steroid, or other solution. not including neurolytic substances, including needle or catheter placement, includes contrast for localization when performed epidural or subarachnoid. So for cervical or thoracic, now you should report 62320, or for lumbar or sacral, report 62322. So for pain management, take a look at your codes. You've got some new codes in here. We also find that the injection procedure, which includes the indwelling catheter placement, continuous infusion or intermittent bolus of diagnostic therapeutic substances, including anesthetic, antispasmodic, opioid, steroid, or other solution, not including neurolytic substances, includes contrast for localization when performed, epidural or subarachnoid. Now this is the cervical or thoracic code is deleted, and you should now report that with 62324, and the lumbar or sacral code is reported with a 62326. So the 4 new spinal injection codes, why were they created? Why would CPT just have codes in place and then delete and create new ones for the same service? So CPT identified these 4 spinal injection codes as being potentially misvalued. And it's because of the manner in which the service itself is being performed. So CPT noted, CMS noted that typically these services are being performed with imaging guidance. So in an effort to value these codes more appropriately, imaging guidance has been bundled into these new codes. Yeah, and here's more description around the new codes. The 62320 is without imaging guidance, and the 62321 of the cervical or thoracic area is with imaging guidance. So if you're not doing imaging guidance, you have the option here to select the code without imaging. And the same goes for lumbar or sacral. We also see with these new spinal injection codes that they are noted by anatomical site, such as cervical, thoracic, lumbar, and sacral. And they're specifying the injections as either intralaminar, epidural, or subarachnoid. And then the imaging type is either fluoroscopic or CT. Okay, so definitely there's changes around the coding for spine surgeons, so be aware. And then here's some information about how the values, how the codes are being looked at and valued for payment. Okay, so moving into the eye area of CPT, there is no new codes and only 3 revisions. So the major revisions happening here are with code 67101 and 67105, and these are the CPT code descriptor is now including the wording here of including drainage of subretinal fluid when performed. And then the second code, 67105, is essentially removing those words. So they like flip-flopped these code descriptors a little bit. And that's it for eye. So if you guys are eye providers and coders, you could all drop off the line right now. Just kidding, please stay. But let's move into radiology. So we have 4 new codes in radiology. We have 4 revised codes and 11 deleted. So a new code, 76706, is the ultrasound abdominal aorta real-time with image documentation screening study for abdominal aortic aneurysm, AAA. So this is a new code that was created, and we have some rationale provided here from the AMA about when we should use this code. So the clinical example of 76706 is as follows. A 67-year-old obese male smoker undergoes a screening duplex scan for abdominal aortic aneurysm. So the screening code is 76706. And this is the reason behind this new establishment of the code is because this is a recommended one-time testing for AAA with ultrasound in men who are aged 65 to 75 and if they've ever smoked. So if they have that risk factor. You'll find these are the deleted codes here in red, 77051, 55, and 56, and they are the mammography codes. So 77051, computer-aided detection with further review for interpretation with or without digitization of film, radiographic images, diagnostic mammography. Now we should report the 77065 or 77066. And we also have mammography unilateral and mammography bilateral are deleted, now reporting 77065 or 77066. So what's new about these codes? So the new code descriptor, again, is essentially updating because of technology and the change and advancement in mammography. The descriptor is stating now diagnostic mammography, including computer-aided detection, CAD, when performed, unilateral or bilateral. The 77052 is deleted, and we are instructed to now report 77067. So this was the screening mammography, computer-aided detection. So the screening mammo code is deleted, now report 77067. And 77057, that's funny, screening mammography, bilateral, now report 77067. And the new code descriptor here is screening mammo, bilateral, 2-view study of each breast, including computer-aided detection, CAD, when performed. And the revisions to the radiology codes include the fluoroscopic guidance codes 77002 and 77003. And here you'll see the revision listed in green. Now the code descriptor says to list separately in addition to the code for the primary procedure. So these became add-on codes. So many other codes, many of the other revisions found in the radiology code section are around the moderate sedation symbol being removed. So we'll talk about that more shortly. And then we have pathology and lab. So there's a lot of cool stuff happening. You'll see 11 new codes here, 7 revised codes, and 8 deleted. And one of the changes here is around drug screening. CPT adopted CMS's current model for its next set of drug screens. Providers will have only one set of rules to follow for these kinds of tests next year. Coders will report one of 3 codes, the 80305 through 80307. Selection is based on method used and will be reported with 1 unit of service. So that's a major change because last year we were reporting these codes for each essay or analyte, and now there's just 1 unit here with these codes. So taking a look at the deleted codes for drug screening, we have the 80300, 01, 02, 03, and 04 are deleted, and these are now to be reported with the 80305, 06, or 07. And we have here new codes, again, are the 80305, 06, and 07. And these drug tests are the presumptive, any number of drug classes, any number of devices or procedure. So again, that's pulling everything that you're testing all into 1 code, 1 unit. And then for deleted path and lab codes, we have the long QT syndrome gene analysis codes. are being deleted. We have the 81280, 81, and 82 are all deleted. And in CPT 2017, there is no indication of what codes to report for these deleted codes, which means that this code is probably obsolete. So it's likely that these tests are replaced by more advanced testing or just have become obsolete in the delivery of healthcare. And we have a new code here, the 81327, which is the Septin 9 analysis. And this is often used to detect and test for the colorectal cancer screenings. So here's something really cool about the pathology, path and lab codes. A lot of the revisions that were made here in 2017 are around the advancements in detecting the genomic sequencing procedures. So they can detect by DNA analysis what is your risk level for developing disease in your lifetime. And now there's a number of tests that are revised to show this change. And also there's some new codes added too. So we have the 81431 and 4, or 81413 and 81414 are new codes regarding the genomic sequencing and DNA testing. And we have more of these codes here. So just take a look, watch your fee schedules, watch your clinical laboratory fee schedule, because CMS had not issued fee schedules on most of these new codes, but you'll see an update coming shortly for these. So here for the code 81539, this is a great new code that was added. This would be used in the example of a 60-year-old male presents with an elevated PSA with a normal digital rectal exam. He's being considered for a prostate biopsy, and the patient is reluctant to undergo the biopsy. So this new genetic sequencing test can identify what is the patient's risk level of developing prostate cancer, the high-grade aggressive type of prostate cancer, in their lifetime. So it's really cool. This is a great advancement in healthcare, where providers may have taken a patient who presented with an elevated PSA, a normal rectal digital exam, and they may have, watched them and said, follow up in a month, 3 months. But now you have a test that can indicate whether or not this patient will ever develop the high-grade cancer in their lifetime. Similarly, we have a new code for the fetal chromosomal microdeletions. It's a genomic sequencing analysis, again, based on DNA. And this is testing the maternal blood during pregnancy. And this will often identify fetal chromosomal defects, and the code is the 81422. So coding clinical example of when to use this new code would be in the example of a 28-year-old female who is 10 weeks pregnant. She visits her obstetrician for routine prenatal care. She has a negative family history and personal history of microdeletion syndromes. The patient is counseled regarding her age-related risk to have a child with microdeletion syndrome. Because the patient's age, the risk of the syndrome is higher compared with other genetic disorders, such as Down syndrome. The patient's blood is drawn and the sample is sent to the laboratory for analysis. So many of us who've had children in recent years have been offered testing to test for, the presence or possibility for developing or, having a child born with Down syndrome. And oftentimes the OBGYN would communicate, well, we can provide this test to you, but often there's false positives involved. And may cause you more upset than it's worth. Well, now there's such huge advancements in the genomic sequencing and analysis, through the DNA, that these tests are being done with high value. So less error, less room for false positive. So this might be a good option for people now to do this genetic sequencing. Here's another cool advancement around the path and lab area in regards to the genomic sequencing tests. The new code, the 87483, is a nucleic acid test, and it's often used to detect a virus or a bacterium, such as HIV. So these tests were developed to shorten the window period of time between when a patient has been infected and when they show up as positive by antibody tests. The nucleic acid testing prior to 2017 was reported for each pathogen tested. Now we are to report code 87483 once per 12 to 25 targets. And this is just a really cool advancement. The clinical example here explains that this code would be used in a circumstance like this. So a 52-year-old male presents to the emergency room department with headache and altered mental status, including confusion and lethargy. He has a slightly elevated temperature and complains of nausea, vomiting, blurred vision, photophobia, and diplopia. He discloses that he is homosexual and has had unprotected sex with many partners over many years. He does not know his HIV status and undergoes a lumbar puncture under sterile conditions. Code 87483 should be coded. So what is really cool about this advancement in the pathology community is that providers can identify, the infection, the disease so much earlier than they used to, which means that the patient can become treated much sooner and their quality of life would be much better. So there's some revisions made in the Path and Lab section, and you'll notice here with these codes in the green, the words are added. For the heavy metal testing, qualitative any number was added. The 83018, not elsewhere classified not elsewhere specified was added. And for the 87304, lipoprotein blood, the word numbers was added. Okay, moving into the medicine section, 28 new codes, 30 revised codes, and 14 deleted. So we have 2 deleted codes here, 92140 and 93965. CPT 2017 provides no replacement for these codes, so it's likely that these tests are just obsolete now. So there's big changes throughout the physical medicine and rehabilitation sections, PT and OT and AT codes. There was some deletions here. So physical therapy, the 97001 and 02 evaluation and reevaluation codes were deleted. And now we are directed to report the physical therapy evaluation and reevaluation codes with 97161, 62, 63, or 64. And the 97161 through 97172 are similar to E&M codes found in the 999 series, but they're applied specifically to therapy. So the guidelines in this area have been added and revised to include definitions very similar to the E&M guidelines. So take a look in your 2017 book, review these areas, and notice, take a look at the definitions. So you'll find in the physical therapy area that there's definitions around body areas, body systems, a review of body systems, body structure, and personal factors. And here's a breakdown of some of that detail. All of this is found in your manual. So the new code 97161 for physical therapy evaluation of low complexity, and it goes on to describe what a low complexity PT eval is. And CPT notes that this visit is typically 20 minutes, which is spent face-to-face with the patient and or the family. And then we have a similar code here, 97162, for physical therapy evaluation of moderate complexity. CPT breaks down and explains what creates a moderate complexity physical therapy eval. and this code is typically 30 minutes spent face-to-face with the patient or family. And then again, we have the 97163, which is the PT eval of high complexity, typically 45 minutes spent face-to-face with the patient or family. 97164 is the PT re-eval code, which is typically a 20-minute face-to-face visit. So face-to-face time requires documentation. Make sure that your providers are documenting their time. And, it doesn't hurt to specify face-to-face. We have 97003 and 97004 are deleted OT codes. That's the evaluation and re-evaluation codes. And you'll see that they're now being reported with these new codes 97165, 66, 67, and 68. So these codes, the OT codes, very similar to the PT codes, are broken out by low complexity as defined in CPT, typically 30 minutes, moderate complexity, typically 45 minutes face-to-face, or high complexity, typically 60 minutes face-to-face. And then we also have the OT re-evaluation code, 97168, which is typically a 30-minute face-to-face visit. So there's coding examples provided here in this slide deck. You can take some time if you do physical therapy or OT coding, take a look at this. It gives some good examples of how to pull out the complexity levels based on the documentation. And then we have some deleted medicine codes here for athletic training, the 97005 and the 97006, eval and re-evaluation. Now we should be reporting the new codes 97169, 70, 71, and 72. And then the new code, the 97169, is low complexity, typically 15 minutes face-to-face. Here's a clinical example coding exercise to go over to look at that, see how to determine that based on the documentation. We also have the athletic training evaluation code of moderate complexity as defined by CPT here. And this would be typically a 30-minute face-to-face time. And then the athletic training evaluation of high complexity, typically 45 minutes spent face-to-face with patient or family. And just like with the physical therapy and OT codes, we have the re-evaluation code, the 97172 for the athletic training, an established plan of care requiring the components as defined by CPT. And this visit, the re-eval, is typically a 20-minute face-to-face visit. So we have some new codes in the medicine section for the repair of a paravalvular leak, and these procedures would have been previously reported with an unlisted CPT code. So these codes now have their own designation in CPT, and they are 93590, 93591, and 93592. These are, again, the percutaneous transcatheter closure of a paravalvular leak, initial occlusion device, mitral valve, and then the 91 is for the aortic valve, and the add-on code 93592 is for the closure of the paravalvular leak, each additional occlusion device. Okay, so we finally got to it. This is probably one of the most interesting updates in 2017, and it's about moderate sedation. So there were more than 400 codes, which included moderate sedation, which have been deleted from Appendix G. CPT no longer defines conscious sedation as an inherent part of any procedure. Codes 99143 and 99150 are deleted and are replaced with 99151 and 99157. It is no longer appropriate to report Modifier 52, which is the Reduced Services Modifier, with a procedure code when you are not performing the moderate sedation. So what precipitated the moderate sedation changes? Changes in the way that medicine is practiced and provided, such as the time needed to complete a procedure, and therefore the time needed to maintain sedation of the patient has decreased. As a result, the new codes are identified in 15-minute increments. The old codes were 30-minute increments. So this is, we're doing procedures quicker, minimally invasive, in and out. And so the amount of time that the patient is actually sedated is far less than what the codes were valued at previously. So now we have 15-minute increment codes. Similar to the previous codes, these codes require that more than half of the time be provided and documented in order to report the sedation service. And look to your plan. Each plan has rules about time-based coding. I know there's the CMS, the 8-minute rule, so just look to your plan around that. As a result of the 2017 physician fee schedule updates, moderate sedation will be separately billed and paid starting in 2017 using new CPT codes. So CPT is breaking out the moderate sedation codes, which creates an opportunity for greater coding accuracy. It's preventing double billing situations in instances where a moderate sedation service was actually provided by a second provider. So this happens a lot. This is very, very common, and this was a much needed change in CPT. Oftentimes providers will go in and perform a procedure, do a surgical procedure, and the provider doing the procedure did not perform the moderate sedation. Instead, maybe an anesthesiologist would come in, or a clinical nurse anesthetist would come in, and they would provide the moderate sedation. But the code that the surgeon or the provider was billing included that moderate sedation. So correct coding was for us to apply modifier 52 if your provider was doing the surgical procedure but not performing the moderate sedation, then you should have been applying modifier 52. So I would dare to say that many of us had forgotten that rule, that many providers didn't even realize that moderate sedation was included in their codes that they've been billing all these years. And CPT and CMS and AMA, they realized this, they figured that out, and they also realized not only that, but it's not fair to the other provider who was performing the service that there was no code that they could actually bill to get paid for that service. So this is just going to create greater accuracy in coding. So like I said before, how regularly did you actually code modifier 52 to indicate you did no moderate sedation? How often did you get paid for it if you did use modifier 52? Or did that cause trouble with your insurance plans? Were they denying the claims? Were they paying you the right fee schedule? It's definitely been a headache on either side of the coin. Whether you were using modifier 52 or not using it, it definitely caused issues across the board. So what should the documentation look like now for moderate sedation? Well, when we're looking at the record, we're going to want to see who performed the service, who performed the surgical service, the procedural service, and who performed the sedation, and how long. There should be documentation of the time spent for intra-service work. And you'll note in the moderate sedation section in the updates in 2017, there's a large description about the time and the time component of the service. And CPT explains that it's intra-service, so it doesn't count pre-service or post-service. It's the intra-service work is the time that calculates for those increments of 15 minutes. So in relation to this change, you'll see that the deleted codes are listed here, and the new codes are listed here, the 99151, 99152, and the add-on code 99153. Again, these are broken out by 15-minute increments of intra-service time based on patient age, And then the add-on code is each additional 15 minutes of intra-service time. Now, these codes describe the moderate sedation services when they are provided by the same physician. So if you work in a practice and you're a coder in a practice and you're thinking to yourself, well, my provider does the surgical service and performs moderate sedation, so what am I supposed to do? Well, these are the codes that you should be looking at and billing in addition to your surgical codes. So these three codes, the 991, 51, 52, and 53, are to be utilized by the provider when it is the same physician performing both the surgical service and the moderate sedation. And then we have these new codes 991, 55, 56, and 57, which are the moderate sedation services when provided by a physician or other qualified healthcare professional other than the physician or other qualified healthcare professional who is performing the diagnostic or therapeutic service. So this would be the case where someone else came in and performed the moderate sedation. These codes are also broken into the 15-minute increments of intra-service time and based on age. The 99157 is for each additional 15 minutes. More revised codes listed here in CPT around the flu vaccine. You'll notice that this change is now stating to report by dosage and no longer by patient age. Here's more of those revisions and what they look like for the flu vaccine. And then we have some new codes listed here around vaccinations. The 90674, 90682, and the 90750. And we find here the revised codes in the medicine section. You'll notice if you take some time and look over these slides later on, what's listed in green is what is added. Now in CPT it's the revised language. So adding unilateral or bilateral, removing the word fiber optic and replacing it with flexible is the primary change happening here. And that's the same on this slide as well on slide 138. Okay, so we can't miss this. This is really nasty. So take a look at the picture, 139, slide 139. There's the code 97602, which is for the removal of devitalized tissue from wounds, non-selective debridement without anesthesia. And this is larval therapy. So that was added here, the revision of the words larval therapy was added. So wound care is being provided using maggots. And this is, it's kind of disgusting, I agree, but it's also really cool because what I learned recently is that maggots will only feed on the devitalized tissue and they will not touch or disturb the healthy tissue at all. So it promotes healing and it's a very effective method for wound treatment. All right, so moving into the revised medicine codes for psychotherapy, we have some new codes here, the 90832 and 90838, and it looks like actually these are the revisions here, the revision being that the psychotherapy for individual patient is now including the patient must be present for all or the majority of the service. And so you'll notice that the phrase and or family member is being removed from the code descriptor. And again, here it details those revisions for the psychotherapy codes. You'll notice that the major change being with patient listed and removing the and or with family member. All right. So category 3 codes, I'm going to skip these. Like I mentioned at the beginning of the of the presentation because most of these we've already gone over. They're revisions or deletions because they're being added into regular CPT codes and chapters. But feel free to review these, take a look at them, and if you have any questions after the presentation, you can email us directly. So looking ahead, one thing that we should probably discuss, it's a major change that is slated for 2018, and this is looking again at the misvalued code initiative. So CMS is looking to transform all 10 and 90-day global procedure codes to a 0-day global code beginning in 2018. Under this policy, CMS would have valued the surgery or procedure to include all services furnished on the day of surgery and paid separately for visits and services furnished after the day of procedure. Congress enacted Section 523 of the Medicare Access Chip Reauthorization Act, also called MACRA, prohibiting CMS from implementing this policy and requiring the agency to gather data on visits in the post-surgical period that could be used to accurately value these services. So because we've never been allowed to report the post-op services, most offices just have a code like an internal code that they use to keep track of the post-op visits, but it's never been billed to the carriers. If it is billed to the carriers, it has no financial value. So there's not a lot of data for CMS to work with right now. So for them to determine how to value these services now, it's going to take some time. So MACRA prevented it from going into effect right away, but it's definitely something that is on the agenda for 2018. And here's a few more slides around the 10 and 90-day global package proposals by CMS. And that concludes my presentation for today. Maggie, we can turn it over to any questions. Maggie, are you on mute?
Yes, that seems to be a pattern for our end today. Sorry about that, everyone. So I know that was a lot of information to digest, so we're going to talk about it for a little bit. Please submit all questions to all organizers, and we'll get through as many as we can. Right now we have one that is in regards to slide 24. Can you provide a little bit more clarification on what the reason is for replacing modifier GT? This attendee just would like a little bit more information on modifier 95.
Sure. So GT modifier was a Medicare modifier, and other plans will often recognize a Medicare-only code, but some plans won't. They won't recognize a Medicare-only code. So CPT is recognizing that and is just creating the official modifier code of 95. So that would be used for any plan other than Medicare.
Thank you. Is the device in 22867 another way of saying artificial disc?
That is a great question. Let me go back and look. Do we know what slide that was on? It was in the spinal section.
Do not have that specified.
I'm going to pull it up really quick here.
In the meantime, we are getting a lot of questions about a handout of this content. In 3 to 5 business days, when I send out the CEU certificates for those who are in attendance, you will also receive a PDF copy of all of the slides that you can review, and you can also feel free to send in any questions via email. If you do happen to need this information sooner than the 3 to 5 window, please raise your hand in here, and I will be sure to get in contact with you and send out those packets.
Maggie, what code was it again, 22?
Let me see here. 22687, I believe. Artificial disc.
Okay. It looks like it is 22867. So this is the, I'll display my screen again now that I stopped clicking through 100 slides. Okay. So this would be the insertion of an intralaminar intraspinous process stabilization distraction device without fusion, including image guidance when performed. I'm not certain. Can you read the question to me again, Maggie? I'm not sure that this is the code that the question was regarding.
Yes, it just asks if that code in particular, the 22, I believe you said 867, if that was another term for artificial disc.
That's a good question. I think I'm going to do some research. I'll take a look at the AMA update. Actually, hold on here. I might have it. I think we will do some research around that, and if we could get back to the attendee who asked that question, we could do that through email.
Definitely. Here's an easy one. When do these codes go into effect?
January 1st, 2017. Yep.
Great. We have another one here that is from a CPT surgery and cardiology coder. When my provider only does the procedure and the sedation, would that be billed with modifier 52 if the sedation was done by the other provider?
That would not be in effect any longer in 2017. Now, instead of using the modifier 52, the provider would instead bill the cardiology procedure code, and then the other provider who's doing the moderate sedation would bill the appropriate moderate sedation code. So there would be no use of modifier 52 for that circumstance.
Excellent. Let's see. Since code 62310 and 62311 are being deleted, and currently we are billing 77002, when guidance is used, will the only options for coders now be the new code with no extra guidance being billed?
That's right. The new codes for those injections there's two options where you could either code the injection with imaging guidance or without imaging guidance.
We have just a couple more questions here. Will the post-surgical visits have any monetary value during the periods of review?
For 2018, where CMS is taking a look at pulling the global days out of the surgical payment, they would be valuing those post-operative services. So they'll be pulling payment away from the surgical payment, which used to be considered a global payment, and they'll likely reduce the surgical pay, the global payment, and then provide a value for what the post-operative payment should be.
Thank you.
Sure.
That appears to be all of the questions that we have at this time. So I'll take just a few moments. Everyone who was in attendance today will receive 1.5 CEUs, and those will be sent out in conjunction with the PowerPoint that is going to be circulating in a few days. I would also like to bring up the fact that we are currently running a special on one of our RN CPC boot camps. This is a nurse-specific boot camp that will teach nurses everything they need to know how to pass the CPC exam and begin their careers as healthcare consultants and fraud fighters. If you are interested in that, you can visit advizehealth.com/events. And if that's all Melissa has, do you have anything you'd like to add, Melissa?
Nope, I'm good. Thank you.
Okay, excellent. So thank you everybody for attending. Have happy holidays and a great afternoon.
Thank you. Goodbye.
Thank you.